Thanks, Mansour. Welcome everybody to the September meeting of Health in Hackney Scrutiny Commission. Hope everyone's had a good summer. I've had apologies for absence from Councillor Rathbone and Councillor Lynch, and Councillor Turbot-Delong may be joining us from Bolivia, but is not yet here. But if she does, that's where she's from, and we'll thank her for making the effort. Because of the tube strike, a number of the officers are going to be joining us remotely, which we understand. And also apologies from Dr. Sandra Husbands as well, Director of Public Health. Just in terms of the normal items, this is a hybrid meeting. Councillor Adams, could I ask for silence, please? Can I just ask for silence, please? Thank you. This is a hybrid meeting with members in the chamber and some members online. For those members online, please don't start conversations in the chat. Please keep your cameras on when it's your item, and obviously please keep your microphones muted when you are not speaking. Members of the press may be watching. We are being recorded and we are being live streamed. I have not been notified of any declarations of interest. Members, are there any declarations of interest? No. Thank you. Then with that, I will proceed to the first of the 4 substantive items on the agenda today, and that's the annual children and adults safeguarding, the City and Hackney Safeguarding Adults report. I understand it's in draft form currently. I'd like to pay our thanks to Dr. Annie Cooper, who stepped down as being the independent chair, and welcome Claire Solly. Welcome, I think this is your first meeting before us, and we'll also be joined by Georgina Dibber, the Director of Adult Social Care Operations. We've got the report, we've had a look at it. Either Claire or Georgina, would you like to give us a brief overview before I open it up for questions? We've got about half an hour on this item.
Sure, absolutely. Thank you so much, Chair. I just want to firstly thank colleagues across City and Hackney for a very warm welcome to myself as the incoming chair. So I started in the role in June this year. They've all been very generous with their time and in supporting me to learn about City and Hackney. So people will have seen the report. It is currently in a draft form, so we still have some publishing to do with that. So it will look slightly different, but the content will remain the same largely. The successes that you can see presented in the report, really for me as an incoming chair, reflect the really strong and effective partnership across City and Hackney. So I just want to extend the thanks to all partners, community groups and residents who've contributed to those successes that you can see outlined in the report. I also would just like to acknowledge and thanks to the previous long-standing chair, Dr. Adi Cooper, who was very generous in providing a comprehensive handover. And again, the successes in the report are as a result of Adi's leadership. The Safeguarding Adult Board, as the title suggests, cuts across City and Hackney. It's a statutory board under the Care Act 2014. The report covers the period from 2024 to the end of March 2025. And I think it's just really important to be clear that the purpose of the Safeguarding Adult Board is to assure itself that local adult safeguarding arrangements and the actions of partners are effective in both preventing abuse and neglect, but also making sure that we're responding effectively when it does occur. So there are a number of key achievements in the report. And I think, against a backdrop of increasing numbers of safeguarding adult concerns and complexity, it's a report to be very, very proud of. The board published 2 safeguarding adult reviews in the time period, and those are referred to in the report. So they refer to JL, who was a gentleman who lived in his own property, and the concerns were related to self-neglect. So there is a published report showing a 7-minute briefing of learning and recommendations on the Safeguarding Adult Board website. And there's been a number of improvements across the multi-agency system. For example, in relation to escalation, housing representation on the Safeguarding Adult Board, and hospital discharge procedures. The second published Safeguarding Adult Review relates to Steve, and that was in relation to a homeless gentleman. And again, there's been a number of key improvements that the Safeguarding Adult Board has overseen in relation to advocacy, strengthening our multi-agency approach, and having a sharp focus on training in relation to palliative care, self-neglect, and the Mental Capacity Act. And what really strikes me from the report itself is the training offer that's provided from the Safeguarding Adult Board. It's a comprehensive offer that's available across the partnership. The contributions to the national footprint from the Safeguarding Adult Board is reflected in the report also. And as I've mentioned before, the really strong partnership. And I think for me that really stands out, both in terms of the case studies that have been provided, but also the partner updates. The final part of the report provides an overview of our strategic plan. So the previous plan ceased at the end of March. So we have, following an away day, using a self-assessment tool in consultation with partners, developed a draft strategic plan, which we will be publishing imminently. There's 6 key objectives outlined in that plan, with a golden thread around mental capacity, making safeguarding personnel and equity. The 3 areas we want to focus on this year, and these are evidence-based from the data and learning from SARS, are self-neglect, homelessness, and financial abuse. And we're developing our work plans in relation to those at the moment. The final thing, and really, really important, is also we're working hard on a community engagement strategy. So we want to consult with local groups and residents in relation to our strategic plan, our priorities, and raising awareness of safeguarding adults across City and Hackney, and using the voice of people with lived experience to make continual improvements. And that includes the voices that we don't often hear. So we're working really hard to build on the existing great work across City and Hackney to use those networks to achieve that. Thank you.
Thank you, Claire. Georgina, did you want to add anything, or can we go into questions? No. Claire, thanks for that. Just 2 introductory questions from me before I open it up. The first is, I mean, you've alluded to it already, but what are you're obviously new to City and Hackney. What's your initial, you've obviously highlighted some of the areas where you think we're doing well. What are your initial reactions on the top few areas where you think we could improve, coming in from your experience? And the second item is just on the SARS. I could be getting confused. I think discharge has previously come up on previous SARS in terms of the mistakes made at the point of discharge. I think previous ones may have been East London Foundation Trust, and I'm not 100% sure which hospital groups or trusts we're talking about. I think it was with the Steve example in this case, but that pattern of that being a repeated issue, other than just the sort of training, is there more sort of follow-up work, spot checking? How can we be more inventive about driving up standards with respect to those benchmark requirements, particularly as more and more people are being discharged quicker because of the pressures on hospitals?
Okay, yeah, I mean, we've got representation from the Trust at the Safeguarding Adult Board, and I also am cited and attend the Safeguarding Committee within the Trust as well. So there's regular updates, and there's a number of assurance groups, both locally within Hackney and across the North East London footprint as well. So it's a continual pattern of working closely together. I know, and I may ask Georgina or Helen to come in here from an adult social care perspective, but there's really strong partnerships and links around the discharge pathways, how safeguarding concerns are managed, a real preventative approach, in the hospitals to ensure that things aren't going wrong, but when they do, there's an open, reflective learning culture, and that we build on that and continually improve. So there's real, I see a very, very strong partnership, and I see a very open and transparent culture that that feels healthy. So yeah, I think it's in a strong position.
In terms of my first question, in terms of what's your key areas for improvement from us?
Sure. So I think in terms of key areas of improvement, one would be to develop our multi-agency data set. So at the moment, it's very focused on statutory returns and adult social care data. So through my inductions, I've been very, very impressed. People have got lots of ideas and lots of data that we are going to begin to build our multi-agency Safeguarding Adult Board dashboard through. And that would be scrutinised at one of our subgroups and then by exception presented to the Safeguarding Adult Board, which is quarterly. So that would be one area. The second one, and I understand the history in relation to this and the attempts that have been made previously, it's about community engagement. So there's lots of really, really good work that's happened in the Safeguarding Adults Board, but it is an area that I feel we need to develop much further and make sure that we have representation from residents, both in relation to hearing what their experiences are in relation to responses to safeguarding adult concerns, but also listening to what they feel are their priorities and being really clear about how the board's responding to that and using that information to shape its key priorities moving forward. So our community engagement strategy is absolutely critical in that space, and that's in draft at the moment. And we're beginning to plan out how we will consult in person, going to community groups across the borough. So I think those are the two main areas I would suggest.
That's very helpful, thank you. And Georgina, did you have your hand up before I bring in other members?
I just wanted to come in on your point, Chair, on the discharge and hospitals. The recommendations and the learning in both cases were quite specific. So in the case of John, the discharge was actually about his home being appropriate and ready. And I think there were challenges around, he'd previously been in temporary accommodation, was quite desperate to be home, but there was definitely concerns about that home environment. And in the second one, it was actually to do with a hostel that he was staying in. And it was again about how do we ensure a safe discharge when we need to get health services into hostels. So there was something about the commissioning and the in-reach of services in hostels. So they're quite specific learning, wasn't specifically so much about an unsafe discharge, but definitely about thinking that discharge planning around individuals who were both quite unwell.
Thank you for that, Georgina. Members, Councillor Lucas.
Thank you, Chair, and welcome to your place, Claire. Wish you well in your role and look forward to working with you. I wanted to ask a question about housing, because I think that point around safeguarding adult reviews and the JL example given within the pack obviously mentions what you spoke about, Claire, around strengthening input from housing partners. And you've mentioned, I think, that you've got housing representation on the board now, and I'd be interested to hear how that's working and what specifically you're doing to strengthen that, because I was struck in the risks and concerns that we obviously know that, you know, within one's own home is where a lot of the alleged abuse goes on in the first place. So that presumably is a pattern that we see go from year from year. So I know you're new to the organisation, so my follow-up question on that is, why do you think something hasn't been done slightly sooner if it's a recommendation from this particular review? Is there an example of that sort of in previous years? Yeah, I'd be interested to hear a bit more about that on housing.
So we, as you've highlighted, thank you, we have housing representation, and the representation from housing actually came from a national recommendation from work that's being done nationally around safeguarding adult reviews. So each safeguarding adult board received a letter to strengthen its connections in relation to housing. And it's very early days for me to be able to answer that fully, I'm afraid. But through my induction and through our priorities, I've met with housing leads, and we're beginning to develop, particularly in relation to the homelessness and rough sleeping action plan, how we can strengthen our response across the partnership in relation to housing. But obviously that would also cut across self-neglect and also financial abuse as well. But having partners at the board, being involved in the subgroups, understanding data, making sure that our systems are talking to each other, and making sure that housing colleagues are aware of the basics of adult safeguarding, knowing how to report concerns, how to use escalation routes, being involved in preventing things happening, but also being involved in working with residents when there are concerns that are raised is really, really important. So, you know, what we want to do is make sure, and unfortunately, and it's not unique to City and Hackney Safeguarding Adult Board, communication and information sharing are always key themes in relation to safeguarding adult reviews. So it's building that multi-agency partnership at an operational and strategic level. And again, it's early days for me to fully understand that across the borough, but it certainly feels in a strong position from what I've seen so far.
Helen, did you want to come in there?
Thank you, Chair. If you don't mind, just conscious that Claire hasn't been with us all that long, so can probably add some operational detail. So I think we've all recognised that housing in Hackney is a very tricky subject that contributes to all sorts of challenges. What we've been able to do, I think, at a more operational level is bring the teams closer together in how they work. We're currently talking to Ricardo about moving the homeless prevention service onto the second floor. So they'll be sat with adult social care colleagues. And we have regular joint meetings now between housing teams and adult social care teams. So a lot of what Claire's talking about absolutely needs to be led at a strategic level, but also needs to be facilitated around the staff working in a different way together. And I think probably we've made some good strides in achieving that.
And I suppose the other point is obviously it's a very fragmented picture on the housing provision with lots of RSLs, perhaps at times private landlords as well. So it's cascading that information to everybody in a proportionate way, I suppose. Councillor Adebayo.
Oh, thank you. On page 13, about the survey, according to what is here, the survey conducted, we have 4,048 people that completed the survey in City and Hackney. However, we are 15% lower than the NEL, 18% lower than the London, 27%, 20% lower than London, and 27% lower than England. What can we do to improve this survey and to get people more involved? And secondly, you said in 2023, we have 2 safeguarding adult reviews. Why is there a lag? And what can we do to improve the situation in the nearest future? Thank you.
Thank
May I
you.
take this?
Yes, thank you. I shall. I'll answer the safeguarding adult review one first, if I may. So in terms of the safeguarding adult reviews, dependent on the complexity and lots of factors, which could be ongoing coroner's situation or the police, they can take quite a long time to complete. But what I would say is we don't have, as an incoming chair, there is no backlog in terms of safeguarding adult reviews, either to be reviewed to make a decision on whether it meets the statutory test, or a backlog of safeguarding adult reviews in process. So everything is up to date. We do have regular meetings to look at the learning and recommendations. And again, I've, as an independent person, have scrutinised those. And again, they're in a very healthy position. So there's lots of actions that have been complete. And we've summarised that to some degree, obviously, for the purposes of the annual report. It feels a very healthy environment in terms of people do escalate cases to me. You know, it's a very open and transparent culture. So referrals will unfortunately come in because things will happen, but it feels a healthy learning culture in relation to the safeguarding adult reviews. So does that answer the question? So I'm not entirely sure it does.
Yeah, well, yeah. I think just on the lag though, is it the case that say you get a referral in the case of Steve in November 2023? I think I've had this answer before, but just to clarify, it's not that the first time you give your recommendations or advice is when this report is published some year and a half or 2 years later. You give, I understand it, interim feedback at a much earlier stage. Is that right?
Absolutely. So from the point of a referral being made, we need to carefully consider lots of different aspects about what type of review it will be, if it meets the statutory test, any immediate action that needs to be taken in terms of risk in the system would be addressed absolutely immediately. And as things develop, the same process would take place. Things don't wait until the report's published. The learning and recommendations as well will continue to develop as the report develops. And there's staff workshops, learning events, and each agency would take away anything that needed to be done immediately.
Thanks, Claire. And in terms of Councillor Adebayo's first question, in terms of the responses and the benchmark figure.
Yeah, so I mean, I think, that speaks, thank you for the comment and the challenge. I mean, it speaks to the point in relation to the community engagement and, really making sure that we are hearing the voices of all parts of the community. So I think there is lots of work to do in that space, and I think it's a fair challenge. The other part of that is I'm really want to develop a you said, we did, so that in next year's annual report, we'll be able to use the feedback from surveys, from consultations with people, to be really clear about the issues people have raised and what the partnership's done in response to that. So there is a commitment from me to make sure that's front and centre in the annual report next year.
Any other members? Councillor Lucas again.
Yeah, thanks again, Chair. Just another quick question, really. I was struck by how in some of the data that you reported, obviously there's some quite strong health inequalities that sort of scream out from that. And I think what's interesting, you obviously have this kind of mantra and sort of strategic framework around making safeguarding personal. So I'd be quite keen to hear a bit more about that. And I think that you mentioned obviously the community engagement strategy you're working on. And again, you might be too new to the organisation to answer this properly, but like if these are trends we're seeing sort of year on year in terms of, health inequalities from certain demographics, was there anything in place before that meant they were kind of in the communities and able to, take that sort of grassroots approach, if you like? Why is it only now that they're coming to this strategy, if that makes sense? Was nothing in place before?
So I won't be able to answer that in fullness, and I'll perhaps invite a colleague to support with the response. There were a number of initiatives and successes in relation to community engagement, which are outlined in the annual report and previous annual reports that are published on the SAB website. In relation to making safeguarding personal and equity and through the lens of health, our strategic plan for the next 3 years, a golden thread, those are both golden threads through all the priorities we're working on. So instead of having them as standalone priorities, we've made a decision that they just impact absolutely everything, and they should be like a stick of rock through absolutely everything we do. So that will be, for example, making sure that we're using feedback from residents to shape how we respond to safeguarding adult concerns. So making information accessible for people. So thinking about digital exclusion, actually going to meetings and having face-to-face conversations and raising awareness in person. Also making sure that our response, and I have to say again, the figures in relation to making safeguarding personal are impressive. So in Hackney, 92% of people were asked, what is it they wanted to achieve when they were involved in safeguarding inquiry. And then 94% of those people who expressed a view, their outcomes were either fully or partially met. So that demonstrates there is an awful lot of really, really good work happening, but there's always room for improvement, isn't there? And the same with equity. I mean, in terms of safeguarding adult concerns, from what I've seen, the data, you know, who we're receiving concerns about does reflect the demographics of the borough in terms of ethnicity. The age group slightly younger than national trends. So predominantly that's the younger population in Hackney, so 26 to 64-year-olds, whereas nationally it tends to be 64 plus white females that is the highest type of person who's referred in for safeguarding adults. So I think there's lots of work we need to do to make sure we're reaching everyone, but I do think it's a strong starting position. And as I say, those are key golden threads through everything we do, which you'll see reflected in the strategic plan.
Thanks, Claire. I saw Councillor Kennedy, then I'll bring in Councillor Adams.
Thank you very much, Chair. I remarked at the Safeguarding Board earlier in the week that I think we're about 2 years since we did some members training, and I think it would be it's definitely time we did another session again. So I'll be getting in touch with all members to offer a full training session that we'll record and circulate as we normally do, because it definitely fits in with that. You know, making safeguarding everyone's responsibility, especially for elected members, is very much our responsibility as well.
Thank you, Councillor Kennedy. Councillor Adams.
Yeah, thank you for the presentation. On page 24, self-neglect has seen a significant increase in both the proportion and number of concerns since the last year, with 155 concerns, 30% report. So we compared to 68 concerns in 2023-24. So I was just wondering, what are the contributing factors to this spike?
So thank you, Councillor. My understanding is that the number of concerns received, certainly in Hackney, are comparable to the previous year. I think the figures I've got are 1,780 for 24-25, and the preceding year was 1,788. So that they are comparable. There was, again, from my reading of the data, there was an increase of, I think it was 36% in the Mental Health Trust in terms of concerns that have been recorded. It's too early days for me to understand the reason for that fully, but it may be something to do with how things are recorded. I know there's been some challenges around data and how that's collected, so it may very well reflect that. But nationally, there absolutely is an increase in safeguarding adult concerns and the complexity as well. So, and the different types of abuse and the emerging types of abuse, particularly with online abuse. So it's difficult for me to answer that. I hope that feels a reasonable response to the information I'm able to say at the moment.
Councillor Adams.
Thank you. It's about the contacting GP access. We know that we are going through digital now. Everything is digital. But if we look at the percentage of people that are using the NHS app and the website, it's lower than those who are that are not using it. It's lower than those who are using it. Is there any plan to get people educated to be able to use the internet in contacting their GP?
I think, Councillor Adams, it's probably better placed to Dr. Kirsten Brown on the primary care when she may come next for in terms of access and contact rather than the safeguarding team. But I think we can hold that for next session because I think it's probably more apposite towards them than Claire being able to answer GP access. I would have thought. Claire, can I just ask, just as a matter of terminology, The SARs are referred to as discretionary. Just firstly, why is that? And secondly, just a little bit of feedback that if there's been a loss of life, to refer to it as then a discretionary, it could be perceived as a bit insensitive. I mean, do you just need to say it? even if that is the technical language, it just looks as if, oh, we don't have to look at, it doesn't quite seem appropriate use of language.
Thank you, Councillor. So the statutory test for the Safeguarding Adult Review is in the Section 44 of the Care Act. And unless that test is, all steps of that test are met, there isn't a statutory duty to carry out a Safeguarding Adult Review. So it's by no means suggesting that it's of any less importance. It's a legal technical term that means that decision's been made actually because people felt it was so important that it hasn't met the statutory test, but they've done a discretionary SAR. So it's a SAR that's done because people felt so strongly that there was, and it's important to say actually as well, there's also good practice that's reflected within Safeguarding Adult Reviews as well as areas of learning and recommendations. But so it's by no means to suggest anything other than it's just the statutory test hasn't been met.
But then what is a non-discretionary SAR? What threshold does that need to meet over a discretionary one? What's the difference?
So I mean, it would be difficult for me to answer in relation to these two cases why that decision was made, because I wasn't here. But if there is a belief that there is value in understanding in more depth how the multi-agency system has responded to this particular context of both, in this example, JL and Steve, then there would be arrangements to do a review. And there's lots of different ways we can do Safeguarding Adult Reviews. There's lots of different methodologies. But it's essentially the same process that's followed, but it's just recognising that it's not a statutory review that's been undertaken.
Georgina, do you want to come in? It's just really, what's the distinction between presumably a mandatory and discretionary SAR?
Sure, and I can tell you why they weren't met in these particular two. So as Claire has said, statutory is where a person with need for care and support has died or suffered serious harm, and it's suspected or known that abuse or neglect was involved. So you have to hit both of those. And in both of the discretionary SARs, an adult with need for care and support has died, but it wasn't suspected or known to be abuse or neglect that had contributed. For both adults, if we look at the information on their death certificate, it was the reason for their death was due to a health condition or need. But I think, as Claire said, people felt really strongly that there was learning, and hence we used a Safeguarding Adult Review discretionary as a kind of as a helpful known approach to how we can kind of take that learning and embed it. Does that help answer?
Yeah, I think it does. Councillor Lucas, did you have anything following on from that?
Yeah, I just had a quick question around that. So, I mean, if there are cases that are this serious, which are essentially being decided on a discretionary basis to have this review in it, could it mean that there are, in effect, quite serious cases that are kind of slipping through the cracks? Would that be a fair assessment of the current setup? Do you think it's fit for purpose? Is kind of what I'm driving at.
So my experience so far, and again, it's very early days, is, and I mentioned this earlier on, I'm regularly contacted if there are concerns about how the multi-agency system has responded. We've actually just this week received a new SAR referral, which will be reviewed and we'll make a decision based on the statutory test that Georgina's outlined for you. So no, I am assured that referrals come in. Any concerns about the multi-agency response are escalated. One of the recommendations from actually reflected in both these SARs was the strengthening and the embedding of the escalation points and routes to the Safeguarding Adult Board, and also the strengthening of what's described as a high-risk panel and the use of other multi-agency forums to support people. So the safeguarding adult review process feels to me to be robust. And actually, I think the reasons that Georgina's given, and again, I wasn't here, actually demonstrates that it is fit for purpose and it is very robust and effective, because the decision was made to do a review into both these cases when actually the statutory test wasn't met. So I think that's a really positive thing.
Thank you, Claire. I just seen the very last question, then Councillor before, and then I'll draw this to a close.
Thank you, Chair. I think the self-neglected kind of the percentage is 30% compared to others. And would we know what age group or ethnicity kind of differences that falls more into that category, and what strategy does you having in place to address that, to reduce the percentage?
Thank you, Councillor. So the I don't have that data to hand, but it's certainly data that we can analyse to show who the age group, the ethnicity, the sex of people who are subject to, who are self-neglecting. My understanding is that, you know, it cuts across all ages self-neglect, and there are particular differences in relation to perhaps younger people who are self-neglecting to older adults. So it's important that that's reflected in our work plan and strategy, and because unfortunately it does cut across all ages. You know, there is a lot of work happening at the moment, both nationally and across London, and something the Safeguarding Adult Board is taking forward around cultural capability. So really understanding our decision making as a multi-agency system, taking into account and to the point raised earlier around equity. So thinking about how people's life experiences, their age, their physical and mental disabilities, ethnicity, beliefs, religion impact on their decision making, and then how the system makes decisions, and being aware of unconscious bias, and you know, all the different systems and beliefs that are present. So there's lots of different factors that we need to think about, and I think it's a very, very helpful comment, and it will be front and centre to our work plans moving forward, not just for self-neglect, but cutting across homelessness and financial abuse as well.
Thank you, Claire. I'm going to draw this item to a close, and thank you for coming with us today. We look forward to hearing from you next year in terms of how some of those priorities are going, and what improvements you've made, and where we are. So thank you very much for you and the team for presenting to that, and please don't feel the need to stay for the rest of the meeting now. So thank you very much, and with that I'll close that item. We're now going to turn to the next substantive item on the agenda, which is the Transforming Adults programme. We're joined by Leanne Crook, who's the Assistant Director of Transformation, Helen Woodland, who's the Group Director, and Georgina, again, the Director of Adult Social Care and Operations. As members are aware, this is a programme that's been going on for some period of time now. It involves Newton coming in and giving guidance and advice and monitoring us as we were implementing the transformation process. I understand Newton has now left us, but we've got a brief slide deck starting from page 47 onwards, giving us an update on what's been achieved from that and what's next. Is it Leanne to speak to it first, and then I'll open it up? Leanne, over to you.
Yeah, is it helpful for me to share the slides on the screen?
Yes, please.
Okay, thank you for that introduction, Councillor Hayhurst. And yes, you're right, we have given a few updates about this programme in the past. So what I want to touch on today is, I'll do a brief recap of where this came from, why we did it, and look at the first phase of the programme, what we did and what was achieved in that first phase, which was quite significant. And then I'm going to introduce to you all today what's in scope for us in the next phase of the programme and where we've got to with it so far. The first phase of the programme started back in November 2023 and it ran until the end of March 2025. At that point, we closed the programme as it was and transitioned into a second phase. That first phase of the programme had 8 very broad work streams. It was a really significant in scale programme. And as you mentioned, 4 out of those 8 work streams we delivered in partnership with a consultancy called Newton Impact. Newton Impact are no longer sort of working with us intensively day to day, but they are coming back next week to work with us to check on our progress and do what they call a health check. So still a partnership, but just a lot more arm's length now. In that first phase of the programme, each of those work streams delivered a number of benefits and outputs depending on the goal of the work stream. And I've tried to summarise some of those in this update today. Some of those work streams now have fully closed. And by closed, it doesn't mean the work isn't happening, quite the opposite. It means the transformation has been delivered and is embedded and is now part of how adult social care does its day-to-day business. Some of the work streams you will see have transitioned into the second phase of the programme, and that is because there is more to be done, different type of work to do next or more work to do. You will be familiar that we do have a 3-year plan in adult social care, which has a number of quite ambitious commitments in it. We're 2.5 years through our 3-year plan, so we'll be having a new one coming next year. The Transforming Outcomes programme has been really critical to help us actually deliver a number of those commitments because they were ambitious in scale. They involved changing quite a lot of what we do and how we do it. And that informed quite a bit of the direction of the programme. And then just for reference, as we mentioned before, we have come to this commission a few times about this programme back from December 2023 when we first started, and we've given 3 updates since. So I'm really pleased to be able to come back at this point with the first phase closed and tell you how it went. Just a tiny bit more context in terms of the wider council transformation. I'm sure you're aware as a council, we've got an ambitious programme of work and there are cross-cutting themes in that. But given the scale of work within the big service areas of the council, you'll see there are dedicated programmes for adult social care, children's and education and housing, and that's sort of where we fit within that. So I think you probably heard me say something like this before, but I think it always bears putting in context. Why did we need to change at all in adult social care? And I'm sure you all know that the demand for social care is growing at a significantly higher rate than we're seeing general population growth. So between sort of 2019-20 and 24-25, demand for our services increased more than 45%. In that time, the budget increased by 25%. So we're seeing a challenge. We couldn't do more of the same. It simply wasn't an option for us. It's how do we continue to meet that need, but do so in a financially sustainable way. Most importantly, though, when we started the work with Newton Impact, we worked with our practitioners to look at all of the people we've worked with, a huge number of cases, to really explore and be really honest and critical and reflective about, could these residents have had a more independent outcome if we could change some of the challenges we faced? And what we saw is that around 57% of the cases we looked at could have had a more independent outcome. And that isn't for want of practitioner trying the brilliant pockets of practice, but just so many systemic challenges that we wanted to improve. So central to why we did this programme was we knew we needed to centre our residents' ability to be independent and support and think about how we best do that. And from that, we knew that we could see financial efficiencies as a sort of secondary byproduct. So that was the goal of the programme. It continues to be the goal of the programme. We haven't changed it. It remains true. We are trying to change how we provide the care and support to better promote the independence of our residents. We're doing it now with every single person we speak to, every interaction we have, but we're making sure those things we put in place are sustainable for us moving into the future, as we know the challenges will continue. As a reminder, these were the 8 work streams. What you'll see is that the ones with the blocked out lines have been fully delivered and embedded into business as usual. So that was the work we did in our long-term care teams. with our learning disabilities teams, hospital discharge. We have our new carer strategy, and we did some great work around tech-enabled living. The work streams that have a dotted line are continuing in our phase 2. So we've got care charging continues, reablement, and our home adaptations, our DFG adaptations program. So in terms of what we have achieved in phase 1, if we start with what we've achieved from a financial point of view, through that relentless focus on looking for ways to keep people independent, the programme delivered over 330k of cost avoidance in financial year 24-25. We were designing and implementing the programme throughout most of that year. So I'm pretty happy that we managed to get to a point to see the financial impact happen, especially given the majority of the time was designing those changes. As of August, just gone, our forecasts say that we're expecting to deliver around £2.4 million of cost avoidance this financial year, and a further sort of 4.1 million of cost avoidance the year afterwards. These forecasted figures exclude any financial impact we are expecting from the work we are doing on reablement. That will be coming later down the line. We're still sort of working on delivering and designing that change, but we know that when we do implement our plans for reablement, we expect to see that contribute to cost avoidance figures quite significantly as well, but we don't yet have that projection. Now, for each work stream, I've got a few highlights that I will run through, but there were many to pick from. Across the work we did with Newton Impact, the main driver we were working on was around a practice and culture change with different tools and support for our practitioners to make sure their practice could be promoting independence as much as possible. In hospital discharge, what that led to in the first year of the programme is we avoided 12,500 hours of home care for people after a hospital stay. And we're on track to reduce the number of formal home care hours by the end of this financial year by 63,000. What's really key about that is we know when someone comes out of hospital, it is often appropriate and needed that they have quite high levels of care and support. And through this programme, we've been able to review people after the hospital stay at home more quickly and more effectively, and being able to reduce their care and support as they've progressed and as they've settled back home, which has meant that we've reduced a dependence on formal care where it isn't needed, and we've been able to help people settle back into their day-to-day lives and regain their independence more. In learning disabilities, again, this was the focus, was how can we support learning disabled adults to be as autonomous as possible to do the things they wanted to do. Largely, we do this through reviewing existing clients because it's a relatively static cohort. And again, we've seen the increases to packages of care at review be 46% lower than we expected. And that from being able to find many more creative ways of supporting someone outside of just formal care. We did also work specifically with people with a learning disability transitioning from children's social care into adults. And again, we've been able to find more creative ways to support them, which has led to support packages being 51% lower than we would have anticipated. Across the other work streams, long-term care is a similar focus again. We have seen 42% less placements in residential care homes than we expected. We've always had a strategy to, wherever possible, safely keep someone in their own home. And we're really pleased to see we've been able to do that more. But we've also been able to make sure those packages of care at home are promoting independence. And we've seen a reduction as a result of that as well. Our tech-enabled living programme has meant that we now have tech-enabled living champions across the department, and we've been able to increase the range and number of residents who are supported at home with technology. We can't disaggregate the figures from the ones I've just given you, but that will be significantly contributing to that more independent care and support package at home. And then lastly, we had our carer strategy. We worked with partners and over 160 carers that helped us to co-produce this carer strategy, which is now in place alongside an action plan. The action plan is governed and overseen by the Carers Partnership Board, of which we now have 15 carers who sit on that board, and carers co-chair it. The actions are progressing pretty well. I picked out just a few, but we are developing a carers awareness e-learning, which was something that the carers really wanted to work on. We awarded the new contract to the carers service in April 2025 to City and Hackney Carers Centre. And we are looking at how and continuing to increase the uptake of direct payments for carers as a way of supporting them to continue caring. In terms of what residents and our staff think, it's not always possible to disaggregate the transformation from everything else because it is so embedded into what we do. And for residents, it's the experience that they have. It doesn't matter regardless of the programme. But what we do know is that in our most recent staff survey, adult social care scored incredibly positively for a number of metrics, showing that our staff are really satisfied with their roles, which is really impressive given the challenges I spoke about. It's not an easy place to work sometimes in social care, but our staff overall were incredibly positive. We also had our first CQC assessment in the summer for the department. And again, we haven't had our formal feedback yet, but we do know that unprompted, our staff were very keen to tell the CQC team about how transformation has helped them to support residents better. So it was really positive to hear that feedback coming from them. In terms of resident feedback, we haven't quite had our latest NHS England survey published yet. It will be published in October, but we have seen our results. And whilst we can't compare ourselves with our neighbours yet until that has been published, we can compare ourselves with ourselves from previous years. And we have seen that for every single metric that we ask service users about, we have seen an improvement. And this is a statistical cohort of people, a very large survey, and we've seen really, really positive shifts, including for their overall satisfaction with the service they get and their care and support, and also those who say they feel they have control over their daily life. So that's been incredibly positive for us to see, to get feedback at such a large scale. If that's okay, I've got a very short video. It's only about 2 minutes long, and I'm going to play it because it captures sort of some of the feedback and thoughts of the frontline staff who aren't here today.
The Transforming Outcomes programme was important because it was absolutely key to make sure that the independence of the resident was the very first thing we talked about.
How can we do things that are better for our residents, driven by and led by practitioners?
Staff are really clear, really reflective, really helpful about the improvements they wanted to see.
So being able to say, this is how we want to work, this is what we want to do, this is what we think will really make a difference.
And that actually, when you followed making an individual as independent as they possibly could be, everyone got a better outcome.
I wanted a way to really listen to staff, to work with them to design new things, new tools, new approaches that we can use day in, day out.
Project staff working alongside operational staff has been something very different for us.
Best thing's been the ability to collaborate with Meeting Europe and with colleagues to get really good data packages to inform practice decisions. So I think before the programme we were a little bit blind in some areas, and what the programme's done is introduce a really rich data source that really informs practice decision making.
It's been such a structured, methodical and measured approach. It's really clear to me that the changes that we've made have promoted residents' independence.
Improving the way that data is captured, increasing the value of the information that's coming out of that, better reporting, making for better decisions.
We introduced something called the Creative Outcomes Forum to discuss cases. I think the biggest achievement is that since the beginning of TOP, we've had 127 residents discussed at COF.
Loads of opportunities like the Creative Outcomes Forum, the Neighbourhood Connect, having those deep dive case discussions with your managers.
We have managed to increase the number of community reviews, which means that it has led to more residents being more independent and getting the level of care that they need.
which is a very good outcome.
We've also updated Mosaic so that it's really easy for staff to be able to record exactly who they've had care charging conversations with.
Yeah, it's really been a good experience. Helped us to realise that we can work in a bit of a smarter way and be clear. Promoted integrated working because we're an integrated team.
The way that we're using data, the way that we're tracking things, and then using that to analyse and ask the right questions, and then being able to look back and see the changes over a period of time. That's felt really good.
I like the building of relationships within the service.
For me, I think it's about the sense of togetherness, just sharing our knowledge. We're one team.
So feeling really confident about the future because we now have the tools and the mechanisms to really understand the flow and demand of the service.
Really, it's about embracing positive change.
Change is good, so I'm excited for the challenges.
The best part about the Transforming Outcomes programme has definitely been our staff and their willingness and energy to try new things.
And to get that feedback from an outside organisation about how helpful everyone had been and how easy it had made the job for them.
Everything we threw at them, they came up with brilliant ideas, creative solutions. They kept going and they centred on what we could do better for residents. And it was really lovely to see.
Fills you with pride for the organisation.
So lots of things have been achieved, but the one that really stands out to me is the difference we've made to residents.
And I just want to say a huge thank you to staff. And we know we've got further to go, but we are heading in the right direction.
Transformation it's been difficult, but we've all engaged in it, and now we can embed it and know that the lives of our residents will be made better by all the hard work we've done.
Okay, it's the end of the very twinkly music, and I'll continue and move on to what's in the next phase of the programme. So as mentioned, some of the things we started in that phase one have continued into the phase two of the programme. That includes reablement. So what we're trying to do and what we're trying to achieve with our reablement project is to implement a social model of reablement that can support more people with a wider range of needs than we can currently, to reduce their need for ongoing care and support. So it's about having more people accessing reablement with a much broader range of needs than we currently can. Home adaptations continues into phase two of the programme. As you'll be familiar, we are trying to achieve personalised and timely home adaptations from the DFG in order to increase safety and independence for disabled residents across the borough. Our care charging work has continued into phase two. We did a lot of excellent work in the first phase to improve our processes, our information for residents and for staff. And in our second phase, we are looking at quite significantly changing our care charging policy, and that's out for consultation at the moment. And I know that's on your agenda later, so I won't talk too much about that one. Building on the work we started looking at tech-enabled living, we've got a slightly broader work stream in this part of the programme, which is called Digitising Adult Social Care. What we're doing with that work stream is really looking at testing and implementing digital solutions across the department, focusing on how can we improve the resident experience and access to our services using digital tools, and how can we support our staff to be as efficient as possible. We would much rather our social workers and our other frontline staff were spending time with residents and doing less admin. So where we can explore technology to help with that, we're doing that. We have started a project called Understanding Demand and Maximising Prevention. What we want to do with this work stream is really deepen our understanding of current and future demand for adult social care, who needs our services, how and when, and what more might we be able to do to prevent, reduce and delay their need for care and support, working with our system partners holistically and in a preventative way. And the last one, the bottom left, is our Preparing for Adulthood approach. Again, we did some brilliant work with learning disabled adults transitioning into adulthood previously. What we want to make sure is that experience is consistent for all people transitioning into adult social care, regardless of their care and support need. So we are looking at creating one team, as opposed to having them separated. At the moment, we have a learning disabilities team and other pathways for different different people. We are looking at having one preparing for adulthood team across adult social care to make sure that we can build on that learning and improve that experience.
Leanne, just because of time, can we take that last slide as read? Because I think it's fairly self-explanatory in terms of the timeline for the different phases. I know I've got some members wanting to ask some questions. Where are we on the savings compared to the target of those savings? I do remember seeing a slide, I think a few meetings ago, of what those targets were. I think at that stage actually included reablement. It's taking that out, which I appreciate. Where are we vis-a-vis where we thought we'd be with those savings?
We are very close to what we predicted. The predictions had reablement in them, and these ones don't. So actually, the figures we have given you today, we are meeting sort of what we expected we would in our medium-term financial plan. The commitments we put forward, we seem to be on track to meet those goals. However, we do expect the reablement contribution to come in 26-27, which will increase it further.
Just before I open up to members, you just said we can't put a figure on that at the moment, but if we the timeline, which I sort of cut you off from going from the slide to, we're currently at service transition. So, I mean, are we slightly behind on that, bearing in mind you're saying you're unable to give us sort of projected figures at this stage?
For reablement, no, we can't. Where we are in the project actually doesn't matter as much, because where these savings come from is every single decision we work with, every single client that comes through the door, we accrue the savings. So that's why the figures go up each year, because we can apply the new methodology working with more and more residents. So we've embedded those ways of working across our team, so we will continue to see that financial benefit year on year. The only area where that hasn't happened yet is in the reablement area. So yeah, we can continue to see the benefit rolling on each year and increasing as the approach rolls out further and further, and as we work with more clients. But we do expect a significant increase in that once we've been able to launch reablement.
And when do we? I don't quite know, because I haven't caught up to speed with this. Have we yet budgeted in a reablement portion into the medium-term financial plan? And if so, what is that figure?
Yes, the figures we put forward in the medium-term financial plan originally were based on us doing the programme in all of the areas. So the MTFP contributions, we're assuming we would have delivered reablement by now. So actually where we are, we're actually sort of slightly over delivering than what we thought we would, because reablement is actually coming in late. So the other work streams are actually over delivering at the moment compared to what we thought. So the delay of reablement is less of a concern financially than we thought it would be. But to make the full amount in the final year, we do need that reablement to come in. But yeah, the figures you saw were assuming benefits from reablement which yet have not been received.
Have you got any, because if it's in the medium-term plan, I just wanted, have we got any figures on that, say, for what we could be looking at on reablement? Because if we baked in a figure to the medium-term plan, we must have some idea on figures.
I don't have them to hand. We didn't separate out in the medium-term financial plan. We just had one overall figure, which was for all of the programme combined. We didn't separate them out. I will have somewhere the separate lines that we did have year on year. They're quite complex. I can dig them out and share them. But the figures for the medium-term financial plan were one comprehensive figure for the programme as a whole.
Okay, I'll leave it there. I would have follow-up questions on that, but I don't want to monopolise. Councillor Patrick first.
I think the achievements have been brilliant so far, although I do query them in the sense that we've been told in this committee that we are the most efficient. We are really working at the coalface and doing all these things over the years. But it's great that the savings are being made. I'm particularly interested in the reduction in people being placed into residential care. I always understood, as I said, that we place people into residential care only as extreme as needed. And I just wonder what's been changed and what the criteria is now. It's great that people have been kept in their own homes, but I'd like to be perhaps reassured that they are being kept in their own homes safely and being able to enjoy their homes and perhaps get out into the community.
Thank you. So it's a very good question. We haven't changed any sort of criteria that for residential care. I want to make that really clear. If someone's needs need to be met in residential care, they absolutely still go to residential care. What we have changed and what we have introduced is really, really thorough ways of supporting practitioners to consider all the different ways in which someone's care and support could be met before going to residential, if that's a safe way to support them. So it's more around support for staff to really be aware of all the different types of ways someone could be supported to remain safe at home, whether that is through sort of technology options or many different things. But we have made sure alongside this programme, one of the key things we've introduced is really robust case oversight and governance. So decisions about people's care are very much, we've got a very strong quality assurance framework. We are really confident that we are making the right decisions and better decisions for people about their care and support as a result of this programme. So I would like to reassure you that residential care is still absolutely explored when it is the right and the safe option for someone.
Councillor Adams.
Thank you, Chair. The last time we spoke about home adaptation, people were waiting for about 368 days for disabled facility grant adaptation. What is the latest on those? Any improvement on the days?
We haven't gone live with the changes to the adaptation service yet, so I wouldn't have expected those times would have changed significantly. We've been designing the new service and we are very excited to launch it in October. The new service we've designed that goes live in October has significantly less steps involved for someone. We've managed to combine 3 separate teams who sat in different places into one effective team. We have a dynamic purchasing system now, which was signed off by CPIC last week. We've done a number of things to make sure that that resident experience can be improved. We spoke to the residents who've had adaptations about their experiences. All of that has been fed into a sort of a new policy, a new service and a new design, but that hasn't gone live yet. So I can't stand here and say we brought down those times yet, but I can say that's absolutely the goal of the service that goes live next month.
Okay, so, thanks for that. Leanne, just before I bring Councillor Lucas in, can I just ask you to take down the slide deck so we can see everyone online? Thank you. Councillor Lucas.
Thank you, Chair. Councillor Adams actually stole my question, but I had one on the sort of digital work stream because I think this is really interesting. So could you explain a bit more about the kind of tools that are being implemented and trialled, and sort of notwithstanding the sort of council's history with implementation of certain ICT things, and what are the risks of that if people are relying more on kind of let's say a chatbot interaction, or they're going through like some of the customer service tools that we see in kind of as consumers, like what are the risks from an interface perspective with residents? Will they be better off or worse off not speaking to a human?
We think our residents will always be speaking to a human in social care, so we don't intend to replace any of our staff with non-human options. But what we've explored so far in the work stream, we are actually sort of thinking about opportunities all the time. But the thing we started with is there are a few tools that some of you may have heard about that get used in the NHS and in many other councils in social care teams that are AI tools that help transcribe interactions with residents into care and support plans, and it can reduce the administrative burden significantly for the workers. But it also can mean that when a social worker is sitting in front of someone they're working with and doing their assessment, which can be a very sensitive conversation, a very long conversation, it means they can be fully present with that person without trying to keep notes and write things down and go away and write it all up. We've piloted 2 different products that are available that can do that. And we've done an evaluation of those to see what residents thought of them, what staff thought of them, how effective they were at sort of making the process quicker. So that's the third thing we've worked on, is exploring use of those sorts of tools in social care. One of those tools has been incredibly popular so far with staff. It was a small scale pilot, so we're at the stage now of considering what next steps might look like for wider utilisation of a tool like that. So that's been where we started with this work stream. We are looking at things that will make the experience better for residents and for our staff first and foremost. So they're the kind of things we hope to explore through this work stream, but that's where we've started.
Other members? Councillor Adams, did you have?
Chair, no, thank you. At the beginning of your presentation, you said that why did we do the transformation? That there's a need increase in the service, the complexity, that there's an increase, and the cost is going up as well. I'm just wondering, like, we have a lot of savings. I'm just worried about the quality of service that we are giving in terms of the savings we are making. How do we marry all these things together to achieve the quality of savings that we are having now? I don't know if that makes sense.
Yes. So did you ask how we're balancing quality of the care alongside delivering the savings?
Yes.
Yeah. It's a very, very good question. I mean, like, as I mentioned before, at the same time as introducing this programme, we've introduced a completely new quality assurance framework, which really gives us much better oversight about the quality of all of the work that we do. But also what's really important is we have a complaints, people can complain, and we're monitoring our complaints very carefully. We're not seeing anything that suggests that the quality of care has gone down. And actually, as I mentioned, our latest service user survey actually suggests that we're seeing this programme resulting in improvements of people's experiences and outcomes. So we have a huge range of metrics, both numbers, but also speaking to people that we use to monitor really closely the quality of our service. It's our first concern. And actually we're seeing that improve, not the other way around, I'm very pleased to report, but we continue to monitor it as part of our business as usual.
Councillor Kennedy, did you want to come in?
No, I was exactly going to make that point. We're not short of good comprehensive surveys of our service users, and to see the results and satisfaction increasing year on year is, and I said this in my interview with the CQC inspectors, is one of the things that gives me my robust assurance that we're providing a good service.
Thank you. I mean, slightly relates to something that's from the following item on care charging. Clearly, with respect to that, and we'll come on to it in due course, we've been more generous than many other benchmark boroughs, say the 27 or so that we looked at with respect to that. Are there any areas that we're looking at here, particularly amongst the future strands, where we're still, when benchmarked to other analogous local authorities, being more generous in the provision? And I say that in the context of the obvious budget pressures we're under as a local authority. So are there any areas that at the moment are flagging a bit as where we're out with other boroughs?
Not that I'm aware of, no. I can't think of anything where we sort of stand out significantly, unless Helen, you have something.
No. So on the benchmarking we've done, Chair, in terms of the cost that we pay either weekly or hourly, compared to the rest of NEL, we are below average for all of the costs of care that we pay. And we have a comparable number of service users. So we're looking at being fairly average in terms of managing demand, and actually slightly above average in managing cost.
And cutting it another way, in terms of sort of how much we spend per head on a package, so not just what we're paying staff, but how much we may spend on a package per person in comparable situations. Is there benchmarking data with respect to that?
There is. The benchmarking data is slightly tricky for us because we all account slightly differently. So if you look at our average published kind of cost per population head, at the moment we're shown as being quite high. In part, that's because we have not submitted statutory returns, or we hadn't submitted statutory returns for a number of years. So the published data is actually inaccurate. And we are now back to submitting statutory returns following recovery from the cyber attack. So it should improve, but it's also about how you budget and account. So we are one of the few local authorities that still have a very significant in-house provision. And therefore the cost of that increases our average per head if you don't exclude it from the calculations.
So I understand that point. And then where do we have the in-house provision? Which area do we have the in-house? Because home care is outsourced. Is it the
Our housing with care services, so our 16 housing with care services and our in-house day service, and of course we then provide transport. So we have a significant number of staff, approximately half the staff in my directorate actually are in our provided services, not in our social work services.
Fine. Okay. And then the only other councillor before.
Thank you, Chair. I don't know if I'm getting this right here. From what I see here, hospital discharge, there were more. We are now reviewing 65% more people in their own homes after staying in hospital. On the other hand, it's saying learning disability side, there's kind of lower in terms of 46% and 51%. Don't you think? I'm just trying to throw something idea. Don't you think bringing the 65% down will save some kind of more resources to boost the 51% lower and the 41% to make things balanced in terms of package?
I'm not sure I understand the question. If we're comparing the statistics for the hospital discharge versus the learning disabilities, that they're measuring quite different things, so they're not sort of a like-for-like measure. They're quite different. So it's sort of not like a sort of one comparable to the other, but I'm not sure I completely understand the question.
Yeah, but I think one thing following on from that, though, Leanne, was a question I had about 65% more people in their homes are now being reviewed. On one level, that's notionally extra work, but as I understand it, that's a good thing because we're discharging people quicker and we're supporting the wider system in doing that, and presumably that review enables us to moderate the packages proportionately that are required. Is that the right analysis of that statistic?
Yeah, that's it, and we're able to do those reviews much more quickly than we were able to before, and the sooner you can do it, the more personalised you can make that service and reduce dependence on the care provided.
The members, are there any other? I was just going to go back on reablement because I think just sort of standing back from it, from a position where it was initially bedded into sort of the financial plan, and to still not having figures on it. I mean, when will we be able to see a sort of clear plan on what we can achieve by reablement, and what, both in terms of benefit for residents and cost efficiency? So when do we expect to see something concrete on that?
Yeah, and I can come back to your other questions about the MTFP as well in a minute. So with reablement, there has been significant delays starting the programme. We are shortly about to be able to make the first part of the programme a reality. Once we've done that, we're going to be working to make those projections. We can't see we're not expecting to see the financial impact of reablement until 26-27, but we will be able to have more accurate forecasts. Now we've got a good picture of what the service will look like and how it will operate, which has taken a long time, and it is sort of quite a complex redesign with a number of stakeholders to work with. So we will be able to have an actual projection, an up-to-date projection for reablement shortly, but we're not expecting to see that benefit financially until 26-27. In terms of the MTFP forecasts and where we are currently without reablement factored in, so for our first year we were hoping to deliver 770, and we delivered about half of that. So we were under projection at that point because of the late start. This financial year, we in the NTFP were hoping to save 2.5, and we're on track to save 2.4 without reablement. And again, that's without the significant benefit from reablement. Now in 26-27, we wanted to save around 5.9. As it stands, we'll save about 4.2, but that's without reablement. So that's where we want to see that reablement benefit come in later down the line. So that's what I meant by, whilst we're not quite at the MTFP target, that is above what it should be, given that we haven't done reablement yet, and we're confident that the changes we will make to reablement will see that difference in the 26-27 forecast.
That's a helpful analysis of where we are. I mean, I think it would be useful when you have a clear roadmap. It doesn't have to be a lengthy one, but a short presentation to this committee on where we are on reablement with timescales, what exactly it involves. Because I could be wrong, but it seems to me, bearing in mind that was initially worked into the MTF, that's probably where the more significant amount of savings could be achieved. These are the other areas on the different pathways. I could be wrong on that, but just from the point of view of supporting the General Council position, it would be useful to get, when you have got an update on that, for us to have a clear presentation in relation to it.
Absolutely.
Members, is there anything else? We're going to go on to care charging in a minute. Is there anything else at this stage in relation to where we are transformation? No. Okay. Well, with that, thanks, Leanne. And I echo Councillor Patrick's observations. So obviously there was concerns initially about whether Newton was a cost proportionate and whether it's spending too much money on consultants, etc., etc. But from what you presented to us, it seems as if savings have been made at the same time as in terms of improving quality. So thank you for your work and thank you for the presentation. So with that then, we're going to go on to the next item on the agenda, which is the consultation with respect of the charging policy. This is item number 6 in the agenda pack. In the agenda pack, what's there from page 63 onwards is the current policy on charging. Actually, if one goes to the blue cover sheet, you can then click through to the consultation, which is a sort of 17-page document, a fairly easy read, which in summary seems to bring us into benchmark with 27 other boroughs that were looked at in terms of their charging policies. Now, I don't know whether Georgina or Helen could just give an overview, please, as to what exactly we're consulting on and where we are with the live consultation.
Absolutely, thank you so much. What I thought I would do, because it is a consultation document, it is live until the 5th of October, and it started on the 7th of July. So what I quickly did, which I thought would be helpful, is just 4 brief slides. These are linked to the members' briefing that was held back in June, but I thought it might be a nice way to go into the different areas that we are consulting on, and then enable, of course, any questions on those specific areas. So just to remind the principles about care charging, so we have the discretion to decide how we charge for care and support, but we do have the Care Act 2014, which is a single legal framework for care charging under section 14 and 17. The changes being proposed in the main are in relation to our adult social care charging policy, and most of them impact our non-residential service users only. So those are for people who are generally living at home in the community, or supported living, or day centres, for example. So it excludes those in nursing or residential care. This means that the changes are going to impact approximately 85% of our current service users, with potentially higher weekly costs if agreed. But it is of note, of course, that a high proportion of people do not contribute towards their care charge. So based on a threshold, certain people don't contribute, and that remains at about 60% of people who won't be contributing towards that cost of care. Very, very brief reminder about why we are making the policy changes proposed. We want to really provide the best possible care. As Leanne talked about, we're facing rising costs and increasing demand, and very much we need to make sure that whatever model we have in place, it's sustainable. Importantly, it needs to be equitable. So as was mentioned, we did some benchmarking with other local authorities and found we are an outlier in terms of our care charging. It means those living in our neighbouring local authorities would have a very different charge compared to someone living in Hackney. So on these next two slides, so as I mentioned, there's not many slides, and I'm happy to kind of pause and we can go through them, or I can speak to them and then we can ask questions at the end. But in brief, I've set out on these next two slides the area within the care charging consultation that we are proposing for changes. So the first area is around our non-residential care charging, as I mentioned. What we are proposing is to consider removing the weekly charge cap. So currently there's a £250 weekly limit. What that means is if your care cost £1,000 per week or £2,000 per week, the maximum you would be charged is £250. This does really impact those who might have a higher amount of capital and then therefore are paying the same amount as someone with very limited income. We are also consulting on charging for the full cost of care. So currently we assess a contribution based on 92% of the cost of care, but we might increase this to 100%. So again, using very simple figures, if your care costs £100 per week, we will only assess you against £92 of that. The third area we're looking at is counting all of the assessable income. So currently we look at 75% of your income that we can take into account, and this is money left after your essential costs. But in the future, we might look at your entire assessable income. And then the fourth area there is potentially reducing the disability benefit disregard. So we might look at reducing the amount of disability benefits we automatically ignore when calculating changes. So that's the first part of the consultation. It's under proposed change 1 on the consultation document, and we're asking residents and members of Hackney to consider how they feel about those changes. The next area we're looking at is something called the minimum income guarantee. Very simply, this minimum income guarantee cover your basic costs such as food, bills, energy, and we have to make sure, so it's a legal requirement, that your income doesn't go below this amount. At the moment, Hackney has a very different way of calculating how much people should have based on those under 60 and over 60. And what we are consulting on is we might start to use the official Department of Health and Social Care rules to figure out the minimum amount of money you keep. And these rules are more detailed and then look at your age, for example, 18 to 24, 25 to retirement age, and then retirement age and older. The final areas that we're looking at within the care charging proposal is a new charge for self-funders. So self-funders are those who have a certain amount of income or assets who generally would pay for the full cost of their care. What we are proposing, because of the work needed to arrange for those who need support with arranging or are asking for our support, that we when we are setting up or making changes to that package of care on their behalf. The next proposed changes are around technology-enabled living. Technology-enabled living is about the solutions we provide to do with tech in people's homes. So that includes our 24-hour monitoring alarm and response to keep residents safe. What we are proposing is we would charge those who are not eligible under the Care Act, so not those people who adult social care have a statutory duty to support. And the final change we're proposing to consult on is the administration fee for blue badges. So we currently issue blue badges for free as a for new applications, renewals and replacements for lost or stolen. I should mention that blue badges are valid for 3 years, which means the cost works out to £3.33 per year. I'm assuming it might be helpful if I stop presenting and then happy to take any questions on any of the parts of that consultation.
Thanks, Regina. And also, you broke up a little bit, so feel free to turn off your video if you wish, because that just might help the audio quality. Just from my point of view, before I open it up, I found the consultation, bearing in mind it could actually be quite complex, actually quite easy to read, and broke down quite complex areas quite well. I thought it was clear. I mean, the only observation I would make is that, just to be clear, on the contribution towards the technology element, whereas all the other aspects have got figures attached and that doesn't. So at the moment, it's just what would be the contribution that we would possibly be expecting for the TEL service. I don't know, are you able to say that, or would it just be the cost of the service, whatever that would be?
Okay. Thank you for telling me about my my Wi-Fi. Apologies. I think it is quite poor at the moment. So we are working to look with a provider at what that cost might be. The cost for those in the community who currently self-fund is often just a few pounds per week. We're not able to confirm yet what that would be, but it would be a few pounds per week.
Thank you. Members? Anything from? No, I can't see any other questions. I mean, thank you for that. I'm just trying to think whether there's any. I'm looking at the other members. Councillor Kennedy.
I was just going to remind members, I don't think all members of Health in Hackney were able to attend, but we did have a fully recorded hour-long briefing session that is online. So it perhaps it'd be useful if I just send that round again to members.
Thank you very much indeed. Georgina, thank you for your comprehensive overview of that. And obviously, it doesn't have to be detailed, but you indicated the consultation closes on the 5th of October. So if it's just the case that you're going ahead. Oh, no, I've got Councillor.
Sorry, just talking about the consultation. What method is being used to consult people? Is it just online? People being dropped, hard copies or something like that? Just something on that.
I think we're also going to the public libraries and speaking to people, but Georgina will be able to answer.
Yeah.
Yeah. That is correct. So I'm happy to send out information on the drop-ins. We have been going out to all the different libraries, and there are still further ones running. It is on our website what the next library drop-in is. We've also gone out to a number of resident groups, such as our carers, adults with learning disabilities, for example, and also paper copies were sent to all of our residents who are in receipt of care and support. So that 85% that I mentioned would have had a copy, so they can directly complete that and post that back if helpful.
Thank you. And what I was going to say was, if it's the case that essentially, by and large, the recommendations you've gone out, or the suggestions you've gone out to consult on, are then implemented post-consultation, if you could just, it doesn't need to come back to us as a whole item, if you just let us know that and keep us informed, because clearly that relates to one of the pathways we were just dealing with. Thank you, Georgina. So with that, I'll close that item, and then I will move on to the last substantive item on the agenda, which relates to the closure of Homerton's Leadenhall Sexual Health Satellite Clinic, located in the City of London on Leadenhall Street. I'm grateful to be joined by the Deputy Director of Public Health, Chris Lovett, Frokes Dominga, who's a Senior Public Health Specialist, who's joining us online, Dr. Lizzie Williams, who's a Consultant in Sexual Health from the Homerton, and I also note, I think Breda, the Chief Nurse, and Stephanie Cochrane from Homerton are also joining us on the call. Chris, are you starting off with this item and then others going in, and then I'll open up for questions?
Yes, if that's all right, Chair. So yes, I'm Chris Lovett, Deputy Director of Public Health for City and Hackney. We're bringing this here because there are a reasonable number of Hackney residents who do currently use the Leadenhall site, and we think that Scrutiny would be interested to know what the proposals are in relation to making sure that their sexual health needs continue to be met. Just to give a very brief summary, Leadenhall Clinic is due to close on the 17th of October. There has been extensive promotion of the fact that the clinic is closing, and that is now including contacting people who are currently using the service and giving them the option of either going online to the London Sexual Health Clinic or potentially going to another Homerton site, or if they wish to choose to go to another sexual health clinic provided by another provider, such as Barts or perhaps Chelsea and Westminster, then we're working with the Homerton to identify how their care can be transferred seamlessly so they don't have to give all the details again when they first attend. But I think Frooks has got some information about the actual number of Hackney residents, and I think Lizzie's going to talk about the mitigations that have been put in place by the Homerton to make sure that access continues to be as good as possible. I think the other thing to reiterate is, so Public Health is the commissioner of this service, and the actual users of this service is a lot of people who are not either City or Hackney residents, because of the very large daytime population in the city, and also because it was quite a good, easy to access clinic. So we actually think the impact on local residents is going to be fairly small, but you will hear a little bit more about why the finances of this essentially don't stack up, and the service use has changed. So I will stop there, and I think Frooks, as I said, has got some of the data on who's been using the service from Hackney, and I think Lizzie will then give a bit more detail about what the plans are around transfer of care. Thank you. Frooks.
Thanks, Chris. Yeah, just for context. So, for instance, in all of the financial year 24-25, there were 831 unique Hackney residents who used the Leadenhall. But for context, the total number of unique users at all the other Homerton clinics was 15,951 people. So we are talking about a relatively, compared to that overall number, a relatively small number of people. In terms of the use at the Leadenhall, it is about per year around 15 to 16% of all the users. But for instance, Tower Hamlets has a greater number of users at the Leadenhall, and also the City of London itself has a fairly modest number of users at the Leadenhall. So it is obviously we need to mitigate, and we have the other Homerton clinics, and Lizzie will, I'm sure, speak to that as well. Plus we have also provision at the clinic that will now be held at the Neiman practice in the City of London itself. There is also provision at pharmacies for things like simple testing, chlamydia treatment, free condoms for young people, different forms of contraception. So we're trying to plan for this as best as we can and ensure that people know their options of where they can go. And considering that the Hackney residential numbers using Leadenhall are relatively small, I think the expectation is that for where they go for testing, we will hope that we will promote SHL further and expect around 50% of the testing to go online, and another 30 to 50% move to the other Homerton clinics. Lizzie, do you want to take it from there? You're on mute. Yeah.
Thank you. Sorry, I'm not used to using Google Meet. Yeah, I'm Lizzie Williams. I'm one of the consultants at Homerton Sexual Health. So first of all, I want to say this has been a very difficult decision. Obviously, we're very sad to be closing this clinic. It's been very well loved by patients and staff, and we thank everyone that's been working there. In terms of the provision for access to other clinics, with the closure of this clinic, there's no reduction in staff numbers. So there will be the same number of staff, but they will be then in our other clinics that we have. So that we'll have more people working at the Ivy, for instance, and at Clifton. So in terms of people being able to access the clinics within Hackney, there will be more capacity for that than before. As Brooks has already mentioned, and Chris, that there is the e-service, which now has more interventions than it did before. So it also has PrEP on it. And people can use community pharmacies.
Lizzie, I think you've muted yourself again.
Sorry, saying yeah, the e-service, also community pharmacies, and they can also access other clinics if they want to. In terms of numbers of people that access Leadenhall, currently about 23% of our users at Leadenhall are actually from Tower Hamlets, and the City of London and Hackney residents added together are less than 23%. So I think it just goes to show that in terms of being a service that is for City and Hackney residents, it's maybe not meeting that need. Open to any questions.
Thank you. Just before I go to
I meant to say about the Neiman practice. So we've now started a once a week sexual health service at the Neiman practice, which is the only GP practice in the City of London. And that started last Friday. All of the appointments were fully booked. I don't know of the number of Hackney residents that booked in, but of the 6 coil clinic appointments, so contraceptive coil appointments, a third of them were of City residents. So it's good to see that they're being well utilised. And I think it also shows really good collaboration between primary care and us. So that's worked well so far, and hopefully we continue to do so.
And thank you all of you for that. I see Councillor Lucas, I'll come to in a minute. Who owns, was the building being rented at Leadenhall Street, or was it owned? And this isn't a loaded question with an agenda, but are the commissioners then reducing how much we pay the Homerton for this service in light of this, or is it the case that we understand service is being provided elsewhere and it's a reconfiguration of service rather than a reduction? So that's not, I'm not making a judgment call on that. I just wanted to understand what the position is from the commission.
So, the Leadenhall Clinic is a private, so it's basically an office block, and we have part of the lower floor of it. The cost is about £350,000 a year for the estates cost. So that's the estates cost and service charges and other things. So it's very expensive. It's our most expensive estates cost for our service, and is the second smallest clinic. It doesn't really represent good value for money. You may not be aware of this, but we, in terms of a service, are in deficit as a lot of sexual health services. In fact, I think all sexual health services in the country are. So the money is going to be used to actually pay for the things that we do, and hopefully not be in deficit.
That's helpful to understand. Councillor Lucas.
Yeah, thanks. I think Chair actually sort of got to the heart of the question that I was going to ask, which is essentially this is about cost, right? Isn't it? I mean, it really is. Sort of to be frank, and I think the point around others from different boroughs using the service. I mean, wasn't there initially a provision in the public health contract around city workers to use this? So I'd be interested to hear your thoughts on that. But I think my question is really around, obviously this will be disruptive to a degree for those who use the service and use the centre. So will there be sort of a feedback mechanism down the line to keep in touch with those who are now using different provision elsewhere, and what their experiences of that are, and how we can just ensure they're sort of getting the best out of that in coping with this change, if that makes sense? Thanks.
In terms of feedback, there is a email address that's been set up specifically for this from our service, so service users can contact that. We don't at the moment have a plan in terms of getting specific feedback from those users about where they're accessing afterwards. I mean, I guess we'll be able to see from our data whether the borough residents that people come from changes or not.
Thank you, Lizzie. Any other questions in relation to that? I mean, you've obviously made the point in terms of other boroughs using it, and you've cited Tower Hamlets as an example. I mean, just as a point of interest, I understand your contracts with Hackney and the logic there. I mean, when something like this happens, are the liaisons with Tower Hamlets Public Health to make them aware that there's going to be dramatic service reduction for their population, and how is that built into the conversation? I'm just thinking more about constructive joint working and forward planning. I see Chris, you want to come in for that?
Yeah, so we have been working on this jointly with the Homerton for I think about the last 6 months. One of the areas that we did want to, because essentially the way that Leadenhall is funded, the majority is not by City and Hackney Public Health Grant, it is funded by the tariff from other local authorities, residents choosing to use Leadenhall. So clearly we had to have a conversation with them about what would they actually want their residents to do. So if this clinic closes, the last thing we wanted to do was put impact on other clinics by an uncontrolled movement of former patients at Leadenhall. All of the commissioners of I think it was the 6, which constitutes 70% of the activity, indicated that they would like their residents to go online, because a lot of the activity actually is possible to be undertaken online. Online service is convenient, it's more cost effective, and for simple things, it's certainly where the affordability comes in. And then if they were given another option, it could have been to ask people to go to the Homerton. They were all very clear they wanted to go to their local clinics. So I think that's sort of, so for Tower Hamlets, it was very much, they prefer people to go to Barts, and for Islington and others, it would be their local providers. So what we have been able to do with the Homerton, because this is one of the first times that a clinic has been closed in London, we want to make sure that we are learning and mitigating the impacts as we go, is that we won't be changing any of the finances for the Homerton until April. We will be reviewing this probably at City Scrutiny as well in January to look at whether the mitigations have been successful. But it is very much, the patient is central to this, and making sure that if they choose to go online, then that's fine. If they choose to go to the Homerton, I think as you've heard, the staff are being redeployed, and so we're confident that there is going to be capacity within the Homerton clinics, and there are a clinic in the north of the borough in Hackney, and also one towards the south of the borough. But if they do choose to go to another service such as Barts or elsewhere, then we will look at what that means for the Homerton's income in April. We're not changing it at the moment.
Thank you, Chris. And Councillor Bear?
Just a quick one. I just want to know the views of the staff about the closure and being having to be moved to other section of the ward.
So there are quite a lot of our staff rotate around the clinics, but there are some core staff that work there. This clinic was open in, I think, April 2018, and a lot of the staff members that are core staff members there have actually been within our service for a very long time. So they've worked at other clinics within our service before. They are very sad about having to, that this is closing. They've put an awful lot of effort into making it a great project. And I said it has had really excellent care and very good feedback from patients. So they're very sad that it's changing, but in terms of working at other sites, they work with these people at the other sites already. So it's not a huge change from that point of view.
Thank you, Lizzie. I don't think there are any other questions, so I might be able to bring this item to a close. Thank you for your comprehensive explanations and the rationale making this decision, which we understand, and understanding the other cost pressures that are on you. Thank you for the work that you do, which we frequently hear praised in other areas and forums. So thank you, and thank you for bringing this to us as well, Chris. Can I just say while colleagues of the Homerton are on the line, I understand there was publication this week of the trust rankings, and I know they're quite informed by certain data sets, but the Homerton did, I think, comparatively well with that from what I could see. So congratulations for your continued work in that regard as well. So with that, I'll bring that item to a close. And members, then it's just the minutes from the previous meeting. Can I have them as agreed, please? The work programme is on the back of the agenda pack, and I think I've spoken to Jonathan. We've got, I think, packed agendas for the next two meetings. I haven't been notified of any other business, so with that, I will close the meeting. Thank you, everyone. 12.